Welcome back to Diabetic Foot Files. I'm Dr. G, and today we're going to talk about the unequal step, how bias, delay, and the system can turn a foot ulcer into an amputation. Like I said, there are so much advanced modalities, but the biggest problem I believe that exists when it comes to diabetic foot care is the resource limitation. And it's usually due to zip code where that area is or what country that is. The resources are extremely limited. And when the resources are extremely limited, the patients usually have to like pay out of pocket or have to go to an area where the resources are unlimited or more advanced so that they could save their foot or save their limb. And I don't think people really talk that much about it because they made me not really exposed to it, seeing it just now and then. But for the past year, I had to deal with that. And it was a big eye opener how serious it is that I don't know how medicine became like this, where it became if you don't pay, you don't get the health care. I did not know it was that bad. Like, that's why you see people like, you shouldn't have to need the money to pay for saving your life. That's not medicine. That's not medicine at all. You're supposed to save the life. You're supposed to save the life regardless of the person being able to pay for it, you know? And it's really bothersome to me that people would be like they would literally stop. They won't do any in certain countries, they won't do anything until the person pays it. And I'm like, "Wow, that is absolutely bizarre and cold," but it exists, not there's no lie about it, it exists. So, let's talk about the bias. So, as we all know, diabetes is one of the most common causes of non-traumatic amputations worldwide, about 80%, right? But non-traumatic amputations now are diabetes related. And like they say, diabetic foot ulcers precede 85% of these amputations. And once a diabetic foot ulcer develops, the lifetime risk of amputation rises significantly depending on the severity and vascular status. Yet, despite it being identical disease biology, Black patients in the US, but actually in other countries as well, okay, 2 to 4 times higher rates of major lower limb amputations compared to white patients across the multiple national data sets. Okay, these are healthcare disparities. This disparity persists even when controlling for hemoglobin A1C, kidney disease, smoking, hypertension, ulcer severity, which means there's something deeper happening besides the biology alone. And there is a bias. There is bias. I don't care what anybody says, there is a bias. I've seen it firsthand. I've seen the very difference of how somebody is treated based on their either their economic socioeconomic status versus their other socioeconomic status that is a perceived bias that the patient might be low income or, things like that. So, the actual pathway. So, for us to understand disparity, you have to follow the timeline of limb loss. So, a diabetic foot ulcer is not static. It progresses through this predictable failure points. You're able to figure out the failure points very quickly. Okay. So, how big is disparity really? So, Black patients with a diabetic foot ulcer are 2 times more likely to undergo an amputation compared to white patients. Some studies show there is a 44% higher risk of amputations in African American patients. In certain regions, the risk nearly doubles or more. Okay. Historically, amputations rates were like 95 per 10,000 in Black patients versus 56 per 10,000 in white patients. And recent reporting is Black diabetics are up to 4 times more likely to lose their limb. And, honestly, I mostly see patients who they said they wanted to amputate my leg. To be honest, I have yet had a patient who was a different skin color than Black who had that story where they just wanted to amputate their leg or amputate their toe. And I'm like, why would they do that? Like, why? Like, it's salvageable. Why would they do that? I never had that yet with a skin tone, another race. Okay. So Black plus rule equals about like 28% risk of amputation or death from a diabetic foot ulcer hospitalization. God forgive me, it's a little late tonight. And lower income patients are 4 times more likely to have a higher amputation risk. And this is what public health experts call a mega disparity. So let's go about the stages. So the invisible injury. So what happens biologically? We already know the peripheral neuropathy causes loss of protective sensation. The microtrauma goes unnoticed. The repetitive pressure causes skin breakdown. And in clinical reality, many patients don't feel. So the first lesion looks like a callus, blister, small fissure, minor skin breakdown. But where the disparity begins is there is less frequent routine foot exams in primary care, lower rates of podiatry access in underserved communities, delayed identification of minor lesions, and studies show preventative foot exams are underutilized in high risk diabetic patients, especially in primary care settings serving minority patients. Now, also the mislabeling. That's why it's a big deal to know that the foot is not black because of the patient's skin color. It's black. Sometimes it's black because of the peripheral arterial disease. I remember recalling telling an incident about it. This patient was being treated by a foot doctor also for calluses. And he kept on saying the calluses were getting more painful and dark. And I was like looking at his foot. I'm like, no, you have peripheral arterial disease. He keeps on cutting and you have no blood flow. Like these areas are necrotic. And he didn't understand what I was saying and what. And I was like, no, like, did they ever do a Doppler? Did they ever take you to vascular? And then on top of that, the patient tells me that he does have a history of peripheral arterial disease, still smokes, it's been a few years since he saw vascular, and I'm like, "But the doctor never referred you after this, and you've been coming, like, once a month?" And, "No, no." And I'm like, "No. Yeah, this is not your skin tone, okay?" And then on top of that, you could clearly see the contralateral leg is a completely different color. The contralateral leg is much more healthy, okay? So, like, mislabeling as well, misdiagnosis, mislabeling happens a lot because at this stage, like, let's say they mislabel the wound, right? So the ulcer exists, but the interpretation of the ulcer differs. So they might clinically, it's like a superficial ulcer or early infection that's stubble. It's really hard to see erythema in a person with a darker skin tone, okay? It might be milder, okay? And the system point failure is if somebody who's biased might say, and this bias is not like really most people's fault. It's a subconscious thing. It's cultural. The person, the doctor, the clinician might say, "It looks chronic. It's small. Well, let's try wound care first," right? They'll try to do the easiest route that's very simple, okay? But in diabetic foot disease, does not respect it doesn't matter about the size. It respects perfusion, infection, and offloading, okay? So regardless of anything, we don't do the easiest route, okay? You treat every diabetic foot ulcer as aggressively as possible. So, like I said, where does bias begin? It's not always overt, it's actually quite subconscious. So, bias in medicine usually isn't someone saying, I don't care about this patient. I don't believe that. It's more subtle and dangerous. So, just like the thing with the Black women having a high rate of dying during childbirth, right? Still in America, right? And the pain tolerance thing. So, there's documented evidence that some clinicians believe Black patients feel less pain, like we have a higher pain tolerance, or that we exaggerated the symptoms. This leads to delayed imaging, less aggressive treatment, dismissed complaints, and in diabetic foot ulcer, you have to remember a delay is no joke in diabetic foot care because it can go in from infection to osteomyelitis to amputation within a few hours, to be honest. So the other assumption bias is non-compliance. So a provider may unconsciously think, oh, they're not taking their meds, like on purpose. Oh, they're not following up anyway. They can't afford treatment. So what happens? There are referrals to vascular surgery, less limb salvage attempts, definitely, and earlier reasons for them wanting to jump to amputation. That's not biology, that's decision-making bias. Now, diagnostic delays bias. Black people are more likely to present with advanced infections and more severe ulcers. but that's not because the disease is different. The disease is not different than anybody else, okay? It's because the symptoms are dismissed earlier and the access to early care was limited for the patient. Now, the delayed window, which is a critical turning point for us. So this is one of the most important phases in amputation disparity. So what should happen? Like within days, you should be offloaded. Vascular assessment, big time vascular assessment, infection grading, antibiotics if needed, okay? Because you need to practice antibiotic stewardship. Early imaging if osteomyelitis is suspected. But me, like I said, baseline x-rays because then you can see the progress, okay? That's me, okay? Everybody has their own way of doing things, okay? But what happens in reality, there'll be, like, weeks of topical wound care. One thing I don't like seeing is they'll be like, "Oh, the doctor was treating me with triple antibiotic ointment," and then you come with this big oozing wound that probes the bone, undermining sinus tunneling, all this stuff, erythema. I'm like, "So they were telling you to put triple antibiotic on this. Okay, then." So repeated clinic visits without escalation, they're like, "Oh, it looks stable." Delayed referral to podiatry, like I told you, you don't know how many patients I've seen that never went to vascular and had diabetes for more than 5 to 10 years. And the real world impact, delays of even 2 to 4 weeks. I think even a delay of 72 hours in a infected diabetic foot ulcer significantly increases hospitalization risk, osteomyelitis progression, a need for surgical debridement, and eventual amputation risk. Now, another thing we have to think about is the structure of healthcare right now. Insurance, insurance, insurance. So, okay. So Medicaid or uninsured impact. So there is an expansion of Medicaid reduced amputations by about 33% in uninsured minority populations. But insurance status, okay, the patient's insurance status directly changes whether somebody keeps their limb. That's honestly the truth, okay? Why do you think there are places with resource limited? There are so much people and even young people with amputations, okay? Because it's a more of a monetary thing for these hospitals, okay? Because if they don't have insurance and they can't afford it, they're like, oh, amputate. They're not going to do incision drainage, or let's say the patient has neck fast. They have to do repeated debridements, right? Probably every other day, maybe every day. Okay, repeated debridements to open up, get rid of all the necrotic tissue. That costs money, that costs time, that costs resources. If the resources are limited or the patient, sometimes an organization is able to eat the cost, or sometimes there's an angel there, like a financial angel, and they're like, "Oh, I'll take care of it." That'd be great. But insurance right now in the healthcare system dictates the reality. Patients with no insurance or, very hard to income for insurance don't get podiatry early. Also, like, you hear the patients call, they're like, "Oh, I need to see if I cover for the podiatry." They may have a high deductible, so they won't go to the podiatry office because it won't be fully covered. They might have a very high copay, okay? They don't get advanced wound care therapies like substitutes and hyperbaric. I had a patient, I needed a wound vac like no other. I needed a wound vac. They couldn't afford it. I contacted different places. I even asked for a charity wound vac. Did not get it. I did not get it. But we were still able to close it without the wound vac. But this was a classic, yes, wound vac negative pressure therapy. But I couldn't get it. I couldn't get it because the patient couldn't afford it. I couldn't get anybody to give me a charity wound vac, which hurt my feelings. And yeah, couldn't even get a payment plan with it. So that happens. They're like, I'm kind of confused what people are doing. They're like, oh, you're lost? No, it's not. What's the whole point of you having it? What's the whole point of making it? To save the limb, right? Or the patient doesn't get revascularization in time. All of these depend on if the insurance can cover it or if they can cover it or not, okay? This is why a lot of systems, healthcare systems default to the cheapest option is amputation, using us cutting it off. Yeah, because yes, wound care is quite expensive. Now, we have to think of the geography of the situation. So minority populations are more likely to live in resource limited areas like where I was brought up, fewer vascular surgeons, fewer wound care centers. I had a patient, I needed to refer them to wound vascular. The vascular consultation alone was over $400. They couldn't. Sorry, I sneezed. Forgive me. Bless me. The patient could not afford that, or well, actually, it got too bad, so bad that they had to scurry up the money from family because they finally realized how bad it was, but that's how expensive it was, and I'm just confused why there isn't a smaller option or a more reasonable option even for the low income patients to get high quality vascular or podiatry care or wound salvage care. There should be a reasonable one, okay? So, another thing, this minority with the resource limitations, fewer vascular surgeons, fewer wound care centers, right? Because of these resource limited, causes a lot of delayed care, longer wait times, and less specialty access. Wound care is a specialty. It's not a one size fits all, okay? Same disease, different zip code causes different outcomes. Now, we have to think about infection and ischemia, which accelerates the biology. So, we already know that the bacteria penetrates the deep tissue, biofilm formation, microvascular disease limits your immune response, and arterial insufficiency prevents antibiotic delivery. So, it creates the perfect storm. So, infection that cannot be cleared and the tissue cannot heal, there, it's really hard to fix that. So, now another thing with disparity amplification. So, studies have consistently shown that Black patients are more likely to present with, like I said, advanced infection like gangrene, necrosis, are more likely to have unrevascularized peripheral arterial disease at presentation, less likely to receive early revascularization procedures before the tissue loss becomes irreversible. Okay? Now, decision point making, limb salvage versus amputation. This is where outcomes diverge sharply. So, the ideal pathway would be vascular intervention, right? Say angioplasty, bypass per vascular recommendation after a very extensive vascular assessment, right? Aggressive debridement, the patient might need negative pressure wound therapy, infection control, and stage reconstruction. And I don't think people understand how expensive antibiotics are. Okay? The ones that we really need to heal the wound, even IV. It's extremely expensive if you're paying out of pocket, okay? And the reality in high disparity settings, late presentation usually means that the tissue is not salvable. No vascular window available. The systemic infection dominates the decision making. So, how much do we remove to save the patient's life? That's pretty much becomes the decision factor for us, okay? So, in hospitals level studies, they've shown like the mortality and major amputation can exceed 20% more in severe diabetic foot admissions, especially in underserved populations. So differences persist even after adjusting for comorbidities in many, but not all. Okay. Now, let's talk about the 5 layers of disparity. This is not just a one thing problem. This is a stacked failure. Like we said, access latency. This is the most important driver. Delayed entry into care includes no primary care follow up, lack of podiatry access, transportation barriers, insurance gaps. So, this will result in a patient arriving at the hospital at a later stage of the disease. Now, special distribution gap. Limb salvage depends on vascular surgery, podiatry, infectious disease, advanced wound care, okay, and endocrinology, nutrition, and physical therapy. But these are unevenly distributed. Rural areas have fewer specialties or specialists. Safety net hospitals have limited vascular services, and then there are these long chain referrals. That's time loss. I've had patients I referred, and they can only get appointment within 3 months. I try to call, ask them to get in. If I get a favor from a surgeon, they're able to do it. So I'm able to get my patients in. So structural neighborhood risks. So high risk environments include food insecurity. We got to think. You already see how the economy is going. I can't get nothing for $100 worth of groceries, okay? That's food for 2 days. So, food insecurity, poor glycemic control, fewer pharmacies and clinics, higher chronic disease burden, reduced preventative screening access. Now, like we said, we talked a little bit about clinical bias. So, bias rarely is overt, but it appears in patterns. The underestimation of pain and severity, delayed escalation of care, like I said, assumptions about adherence, blaming it on the patient, and normalization of chronic ulcers. It's not normal to have a chronic ulcer. It's not normal. That is not normal. That means something is wrong. There is a blockage. There is a block. So even small delays in diabetic foot disease matter. And our system capacity limits. So even when care is appropriate, there'll be limited OR availability for revascularization or delayed imaging, overcrowded wound care clinics, and inconsistent follow-up systems for the patient. So how can we prevent this? How can we actually fix this? One, we can do any ulcer is an urgent pathway model. That's one way to fix it, okay? Every diabetic ulcer should be automatically treated with a vascular assessment within a few days, infection classification, offloading device immediately, and specialist referral without delay. No subjective filtering. Next is time to intervention metrics. So hospitals should track time from ulcer to first specialist visit, time for vascular imaging, time for antibiotics if infected, time for debridement, because disparities hide in these time gaps. Now, bias abrupt interrupt training, okay? So clinicians must actively counter this quotation, it's small, so it's not urgent, lies. They can try outpatient care first. Another lie. This looks chronic, not acute. Lie. Okay? And in diabetic foot disease, size does not equal severity. Now, race stratified outcome audits. So institutions must track amputation rates by rate. Right by race, I mean. Ulcer to amputation progression with time. Revascularization rates by demographic groups. So if the disparities are invisible in data, they persist in the outcome. And then one of the other biggest things is early screening expansion. Prevention must move upstream. So annual diabetic foot exams, neuropathy screening, vascular screening, and high risk patients, education on minor foot injuries and medical emergencies. And then community level intervention. So, mobile wound care clinics by an actual wound care person who's trained, not just somebody who decided that they just want to dress things because that's how people still end up in the ER. And I'm like, who treated you? And it's like this random person. I'm like, what? And I'm like looking up the person. I'm like, where's the training? Why were they treating your foot and they're not a podiatrist or wound care specialist? Why were they treating your foot? Community podiatry access, health, home health wound monitoring. Telemedicine wound follow-ups are good too. I mean, that's why I give my patients my WhatsApp, okay? Like I said, a lot of people say, "Gabby, don't do it," but you know what? It has done me better than harm, to be honest, because I catch a lot of gaps. My patients contact me right away if they can't get an appointment with a certain specialist, or if, let's say, the people reschedule them unnecessarily. I'm like, "Why did they do that?" Like, I'm contacting them right away. Get him in to get the patient in. My patients will tell me. They'll be like, "Dr. Gabby, I tried to call and make appointment with you. They said that you were fully booked, whatever." I'm like, "No, I'm okay then. Still come in because I'm seeing you. I'm the one seeing you, okay?" And then no, I'm seeing them, okay? But I have caught in a lot of lies and gas by giving my patients my number. That's one way I've been able to jump over that hump where there are people in between that just I don't know how anybody can make other decisions for me through that. Like, oh, she can't see you today. What do you mean? I'm here. I can see the patient. But I'm always available for my patients, especially the ones any patient. I'm always available, okay? And that's another thing. I hate it's like something happens to the patient and I was never contacted about it. Okay then. And if something worse happens because you didn't contact me, whatever, that doesn't make any sense. It's best to contact me, you know? That's why I say I always give my patients my number, my personal number. Any of my patients are able to contact me. That's what I'm here for. So, also, what do you do? So let's do the real world question because I just went on a little rant on there. Immediate clinical approach. Treat first, figure out the payments second. Okay? Ethically required in many situations, okay? I I didn't think I learned this from my daddy. I think I inherited it from my daddy because my daddy never really talked about money like that. But my daddy definitely was the person who, if you don't have it, that's okay. And like, let's say procedure is like what? Let's say the procedure is like 1,500, right? And the person only has 100. Daddy will do it. My dad will still do it. My daddy was a good person. Like, he got into medicine for the right reasons, and I feel like I inherited that from him. I'll never forget one time when I was in school, and, like, this person, I think they got either shot or some type of injury, they stopped by my daddy's office because I guess they were too scared to go to the hospital, and yeah, like, I think he w I don't know exactly, but they trusted him enough, okay, to come to him and, you know, get treated, figure it out, and then probably had to go to the hospital to see him there, but regardless of anything, it's good when your patients can trust you. Now now let's think about some practical workarounds. So, use your hospital system if it's not corrupt. So, charity care programs, sliding scale clinics, teaching hospitals are great, in my opinion, okay? Low cost but effective interventions, so like total contact casting. If you can get charities to give post op shoes and cam boots, that's great. Aggressive offloading, basic dressings can be done. That's advocate hard for your patients, okay? Push for vascular consultations right away. Anyway, okay? Document severity clearly. Use words like limb threatening and high risk for amputation. Then also leverage the programs like pharmaceutical assistant programs, like Good RX, things like that. Nonprofit covering wound supplies, community outreach clinics, and build networks. All we wound care physicians, we all know how networks work because we definitely can't do it alone. So as a provider, you should know your local surgeons who are willing to help, willing to be flexible when it comes to payment, know clinics that can accept uninsured patients, create referral pathways before you need them. Okay. And then the hard truth is, disparity is not genetic. It's not because, a patient due to their race or ethnicity are more prone biologically. It's not that. It's because of access bias, insurance, geography, and system design. So, in closing, amputation in diabetes is often framed as a medical failure, but in many Black patients, it's actually a system failure. Same move, different treatment, different outcomes. Diabetic foot amputations are definitely not random outcomes. They are at the end point of delayed recognition, delayed referral, uneven access, and systemic blind spots in a time sensitive disease. Diabetes is a time sensitive disease. And the hardest truth about this is in diabetic foot disease, like they say, time is tissue and unequal time creates unequal limbs. So this is Diabetic Foot Files. I'm Dr. G, and take care of your feet because they take care of you.